Heavenly Father, we thank you, Lord, as we come here to look at the business of this Human Services Department, Lord. Please help us to keep our minds straight, O Lord, as we think about and guide us, O Lord, that we might be able to give some advice where necessary or where we can for the betterment of the citizens of Union County, North Carolina, O Lord. We thank you for the leaders, these directors, O Lord, and the staff, O Lord, that do the daily work, O Lord. We thank you for allowing us this opportunity, O Lord. In Jesus' name, amen.
Amen. Thank you, Mr. Ford. I'd like to start this tonight with the approval of the minutes. Has everyone had a chance to read it? Do you have any questions? We have a motion.
Motion.
Thank you.
Thanks, Ashley.
Thank you. Do we have anyone second?
Second.
Thank you very much. So the minutes have passed. Next up, we'll want to approve tonight's agenda. Has everyone had a chance to read over it? Any motions to approve?
A motion to approve.
Thank you. Thank you. Any opposition? Sorry. And so it is approved. Thank you. I want to take a few minutes before we get started, actually. This is not on the agenda, but I hope that this is okay. We'll see if it is with everyone. We have 2 new people tonight that are joining us that I'd like everyone to meet. And I think it'd be great if we took a moment, if y'all are in favor of this, to introduce ourselves to them as well, to our 2 new board members. So the first is Eric Clayfin. Mr. Clayfin. Hi.
Hi, good evening.
So he is our new community member. Very nice to meet you. The next is Dr. Matthew Childs.
Right here.
Thank you very much.
Thank you.
He is our new psychologist.
Thank you.
Very nice. Thank you. We're great. We're very, very grateful.
Good evening. My name is Jackie Morgan. I'm the Human Services Business Operations Director. I have the front of the house, the back of the house, and some of the guts of the house. IT, business processes, QI, things of that nature, and some programs like accreditation and prepare.
My name is Janet Payne, and I am the Executive Director of the Human Services Agency, so I have the good pleasure of being able to work and support all of these teams. I will also say that 2 of our directors, Stephanie Starr, Tracy Colley, are not able to be here tonight, and Tracy is responsible for public health, and Stephanie is responsible for community support and outreach, which includes senior nutrition, the WIC program, several of our emergency assistance programs, and outreach, as well as education in the community.
Hello, my name is Ashley Lance, and I am your Social Services Director. I do all of the social services, and we will get into that when we have our and being a part of this.
I'm Brandy Smith, and I am part of the Consolidated Human Services Board.
I'm Susan Marciniak. I am a volunteer on the board as well, and I in the role of other.
I'm Matthew Childs. You're talking to me, I guess. I'm a psychologist and I'm a therapist, and I work with adults and older adolescents. I have an office in Charlotte and I have an office on Main Street in downtown Monroe.
Thank you. I'm Earl Ford. I'm volunteer on the board also, and I'm under the veterans, I'm a veteran of the United States Air Force, and I guess I'm on the board as a consumer.
I'm Amy Dickey, and I'm also a volunteer on the board, serving as the chair.
Hi, I'm Michelle Marcano. I'm the Director of Veteran Services.
Hi, I'm Eric Claflin. I'm the Deputy Chief of EMS at Union. I live in Waxhaw, lived here for about 5 years.
Good evening, Craig Colash, I'm the physician, at least I was, being voted on tonight, so it might be short-lived. I'm a general surgeon, and I generally work out of Matthews, but with no bond.
Hello, I'm Teresa Torres, the Director of Transportation.
Hi, Laura Gardner. I'm in Union County Transportation. I'm an employee and I'm one of the presenters tonight.
My name is Brandon Earp. I am the Operations Manager for Transportation.
Jason Gurrian, Emergency Preparedness Coordinator for Human Services.
Communicable Disease Supervisor with Union County Public Health.
Ashley Burtz, Nursing Director with Public Health.
Craig Greenlee, lead nurse for the communicable disease, and work with Megan, learning the whole new role here.
Next up on our agenda is the Executive Director's report. Assuming we did this.
Good evening. Tonight we have one item that I would like to put forth for your consideration. You have in your packet an application from Craig Kalash, who would be applying to fill a second term as the physician position. And what I'd ask you all to do is consider whether or not you would like to make a recommendation to the board of nurse to reappoint him.
Do I have to step out?
No, you just can't vote. And if you want to step out, you can. If you, Amy, I'll let that be your call on that one.
If no one opposes to Dr. Kalash staying in, thank you. And I'd like to open us up with a recommendation that we do put him through to stay.
Sorry, you're not getting out of it, Dr. Colash.
A second. Sorry. Second? Any opposite? Just any? No? Congratulations on your new term.
All right, now it's working. Thank you.
Excellent. I don't have anything else right now. I do have a couple of updates that I'll do when we get to the update portion, just for some of our different programs. And I would also say that do plan, so we did just pass, or we didn't, the Board of County Commissioners passed the budget. And so we just started our new fiscal year as of July 1st. And we will be bringing forth some budget report information for Human Services as a whole in the next board meeting. I wanted to be able to close, share that information with you as well. So, but very appreciative to them and to the county manager, obviously, for their support of all of our programs. And it is never easy to allocate scarce resources and make the most of them, but they do an excellent job, and we're very appreciative.
Thank you. Before we move on to the next section, I did want to draw attention that Jill James has been serving as our nurse, and she has submitted her resignation that she is going to have to leave us. And so that will leave a position open for a nurse. We also have 2 slots for consumers, a dentist, pharmacist, optometrist, physician or psychiatrist, and then the new nurse opening. So I wanted to make everyone aware so that you can help spread the word in the community for those positions. And then we will go next to our division report.
So the first report is regarding the measles tabletop exercise, and that will be Jason Gurion providing this update for you all.
Really
Jason, you have a mic?
I don't need a mic.
Yeah, you do. That's great.
Damn it. Hello.
It's for the people at home watching.
Is there anybody at home watching?
There is.
Oh, wow. I apologize to them. If you haven't gotten a packet yet, there's one down there at the end over by Ashley. You guys can take one of those. Absolutely riveting stuff that is in there. I have divided it, there's 3 sections. The first section is a brief synopsis of what we did in the measles tabletop exercise. The second part is the actual after-action report after the measles tabletop, and then the third part is all the slides that you guys are going to see tonight. There's only 64 of them. This should only take about 2.5 hours, so just bear with me. Just kidding. All right, so I do appreciate the opportunity to speak with you guys tonight. I will be sharing the results of our measles tabletop exercise that was held on July 9th, and some of the key lessons that were learned. This is part of our ongoing commitment to keep Union County prepared for public health incidents and public health threats. This exercise was done using the federal model, which I won't bore you guys with, but the federal model that we utilize for all exercises, and utilize the 15 nationally recognized public health preparedness capabilities. We tested 5 of those capabilities during this exercise. I'm sure we tested more, but I only wrote about 5 of them. So we'll only talk about those. So the exercise simulated a large-scale measles outbreak in Union County, beginning with a family who traveled from El Paso, Texas, which is a current hotspot for measles. Complexity. We had over 20 agencies that participated in our exercise from the county, from community partners, and you guys will see that here in just a few minutes. We utilized 4 different phases, which again, I'll elaborate on here in just a little bit. And the whole point was to test our current capabilities and come up with some plans to make it better. All right, so these were all the participating, agencies that took place. Obviously, the big ones, Atrium and Novant, were both present. As far as emergency services go, we had Union EMS, Monroe Fire Department, Waxhaw Police Department all participated. Union County Public Schools and Union Academy, both being, obviously Union County Public Schools is the largest educational facility or group in the county, and then Union Academy being the second one. We were thrilled to have them as well. South Piedmont, Wingate University, and then a host of other community partners, specifically daycare centers, child care centers that were involved in this. So that's the entire list that showed up. These partners not only contributed to the exercise, but are critical in carrying out any of our improvement plans moving forward. And obviously, they're people that we're going to have to work with should a measles outbreak occur here in Union County. And when we look back at this exercise, it's clear that some of these partnerships really shine. Like, we have great relationships with certain partners, and then there's other ones that we need to build and work towards strengthening those relationships. So this was the overview here. Again, there was a scenario trigger with the family who returned home. It was a vaccine-hesitant family, or an unvaccinated family who returned home from El Paso, Texas. The situation quickly set in motion a coordinated response involving not only public health and other entities within the county, but quickly involved Union EMS, Monroe Fire Department, Waxhaw Police Department. All of those people, quickly had to have a part in it, and then obviously the school systems and daycare centers that were involved also. The simulation covered the entire arc of an outbreak from the first case all the way through containment, and we did this, what did we do, 5-6 hours? Something like that, 6 or 7 hours. So it was really condensed, but we did the whole gamut of an outbreak. The basis of the outbreak came from Megan and I attended one as evaluators in Mecklenburg County in April. And once we returned from that, Dr. Keener strongly encouraged us, basically voluntold us that we were going to do one here, and he wanted it done before school went back in session. So with the assistance of Megan and Daniel Pena, who's the backup preparedness coordinator, we really put this thing in high gear pretty quickly. And the results that we got was fantastic. First of all, the response we had from the community, our partner agencies, and then just the conversations that were had at the table. So this is the timeline that we utilized, the 4-phase approach. Obviously, the first phase is the return home. They come home from El Paso. They're within that incubation period. They're going about their normal everyday experiences. We had a family member who worked at Wingate University. We had a child who attended a daycare center, another child who attended a Union County public school, and a father who worked in a high-risk environment at one of the chicken processing plants in town. So a lot of exposure opportunities for those people. Obviously, they didn't know they had measles, so they were just freely spreading it, around the community. Phase 2 really covered days 4 through 10, and phase 2 is when it really started to ramp up. It was the discovery phase. This is where people started, arriving at urgent cares. EMS was called to one residence. A family member was arrested, had to be taken to jail. So now we're introducing the jail into this whole thing. And then phase 3 was the peak phase. I think this was the most challenging one for us because this is where the media gets involved. The schools get involved. You start dealing with a lot of absenteeism. You start worrying about continuity of operations plans for not only Union County, but other businesses that are out there. And then phase 4 was day 28 plus. That's our aggressive public outreach campaigns, working with quarantine orders and contact tracing efforts, which obviously is a huge challenge. So each one of these phases individually tested our ability to adapt, escalate, and respond as needed. The exercise work that we all came together as a group, I think there was 68 of us. We all came together as a group. We discussed what the phase was going to look like. We discussed some of the highlights of that particular phase, and then they were broken up into groups. So we had the public health group, which included a lot of our public health staff. We had the community partners group, which was EMS, fire, law enforcement, our daycare centers, and our school systems. We had the healthcare group, which included one representative from Wingate who handled the healthcare at Wingate, and then the hospital systems. And then we had our executive team, which was predominantly Union County, our legal team, our directors, emergency management, and most importantly, our public information officers. They were all part of that group. So once we got done with the big group setting, we broke into smaller groups. We had individual challenges and injects that they were presented with. And then once that was done, we all came back together and we did a report out. And during that report out phase, our exercise facilitator, Mr. Kevin Staley, had questions that he would pose, and he would tie things together, right? So a community partner probably faced this. How does that affect the executive group? How does the executive group decision face, the public health group? So we tied all those things together during those large group sessions. So again, we tested the core capabilities. There's 15 core capabilities that I have to live by. Everything that we do in public health preparedness response revolves around the 15 core capabilities. We tested 5 of those. The first one's emergency operations coordination. All right, this is the activation of the Emergency Operations Center, a unified command structure, and then resource coordination amongst not only us, but our partner agencies. The second core capability that was tested is emergency public information. All right, this is the messaging that goes across all of our agencies, all of the other agencies that are out there in multiple languages. And then the big thing is countering misinformation that may be out there on social media or in traditional news media. Non-pharmaceutical interventions, school closure decisions, isolation protocols, restrictions on visitors and movement within healthcare facilities. Obviously, that's a huge thing that we have to deal with. Information sharing. This is information sharing between public health, Novant, Atrium, within the county, outside the county. So who gets what information? How much are we allowed to share? How much do we have to hold back for HIPAA reasons? And then the last one is public health surveillance. Case detection. The big one for us is contact tracing, epidemiological investigation processes. Contact tracing for something like measles is very, very challenging. And this was something that we really focused on during this. So in order to understand where Union County is as far as our concern for measles, you have to understand where we stand as far as our vaccination rates versus the national average and the state average. And I think that Megan's going to go into more of this. And I'll tell you right now that some of these numbers are a little bit off. I saw Megan in the mailroom a little bit earlier, and she actually mentioned that the 2024 numbers had come out, and she'll tell you about that when she does her presentation. But you can see that the Union County rates are well below the state and national averages. So measles requires a 95% vaccination rate within the county in order to achieve herd immunity. And in the fall of 2023, we were just over 90%. So we fell well short of where we needed to be for that herd immunity. And our exemption rates seem to be more than doubling or over doubling since 2020. If the current trend continues, exemptions could reach 13% by the time the 2025 numbers come out, which is astronomical and rather alarming. Where we're seeing the most of this is with our kindergarten exemption trends. Over the past 4 years, both medical and non-medical vaccination exemptions amongst kindergartners have risen sharply. 103% increase in exemption rates is strongly tied, in my opinion, to misinformation and growing vaccine hesitancy for various reasons. These exemption clusters oftentimes will follow groups, either schools or religious groups, or sometimes even neighborhoods. So that increases the likelihood of sustained transmission. It's not just one-off here and one-off there. You're getting a lot of people who are unvaccinated in certain areas. This is why our proactive outreach, education, and engagement with parents, schools, and community leaders is so critical to maintaining this herd immunity. So with those risks in mind, and with the results, we're going to show how the vaccination gap could directly impact our ability to respond. And this is going to bring us to the next slide, which is our capability analysis summary. All right, we did just focus on Union County. So if there was a gap within one of our partner agencies, we discussed it, but that's for them to fix. We were just focused on Union County and what the county government can do in order to address some of these gaps in our operations. So the first one's our continuity of operations. Staffing plans are inadequate for extended operations. Isolation protocols for essential employees are currently incomplete at a county level. And then remote work capabilities are obviously limited for key functions. You can't be a nurse in public health and work remotely. It doesn't work. I can't do my job remotely. Emergency management, transportation, they can't do their jobs remotely. So we need to address some of those things and figure out how to continue operating at the high level that the county is used to, even with an outbreak like this. Some surveillance network gaps. We're seeing a larger increase in the non-Novant, non-Atrium standalone urgent cares and doctor's offices. And they're not getting the same attention that the Novants and Atriums are. Novant and Atrium, they have epidemiological officers, they have infection control officers. Some of these standalone, buildings, we don't have contact with them, we don't communicate with them. So that's going to require Megan and I going out there and physically talking to these doctors and administrators to bring them on board so that we can have that open line of communication with them. Vulnerable population protocols. So the jail outbreak containment procedures are undefined. Medcos, who are our new jail administrative, or our new jail nursing staff, were not present during this. They were invited. They just, we didn't see them during the exercise. Protocols for homeless populations. Obviously, some of our homeless camps with a lot of people who are vulnerable, getting out to them and getting information to them. And then quarantine enforcement mechanisms are kind of unclear. How are we going to enforce these quarantines if people don't want to stay within their homes? And then last but not least, we have some technical limitations. Our CAD system, getting information to the CAD system, it doesn't lack the capability of flagging potential. It just, there's no mechanism to go from the health department to the 911 center currently. There's no protocol to flag some of those addresses. We did during COVID, and then it kind of went away. So we need to revisit that. So when we start having some of these communicable diseases, they get out there. And then, just as a side note, we also have with Union EMS, they have a different system than the CAD operates. So seeing some of the history and flags of those addresses for them isn't possible. So we need to address that. So our paramedics are just as safe as every other responder going out to these addresses. So what are our corrective actions? Obviously, COOP planning is number one, continuity of operations plan. Now, I'll tell you that public health has a COOP plan in place. It's a requirement that I have for our accreditation that we have a COOP plan in place. Jackie and her staff developed it 10 plus years ago. Over the past couple of years, we just built upon it. So we have one for public health. It is not for human services, it is strictly for public health. The county is currently working on addressing the continuity of operations plan, which again, Jackie has taken point on for our human services team. And hopefully that will be turned around sometime soon. But we really need to operate, or we really need to figure out what our COOP plan is so that if we do have an infection within the county, we can continue operating the way that we are. Again, healthcare integration and engaging healthcare and urgent care networks through our annual training and exercise participation, just getting out there and communicating with them and having those open lines of communication. We are working for technical upgrades, figuring out a protocol to flag those addresses in CAD and then remove them from there once the threat is gone. And then we're looking at a community engagement. How are we going to target these high-risk populations? How are we going to target the vaccine hesitancy that's out there? One of the topics that was discussed, if you remember during COVID, Dr. Keener was very forward-thinking and was out there in the community talking to some of these underserved populations and trying to get them to understand where the health department was coming from, addressing any vaccine concerns they had during COVID. And I think that's the method that we really need to look at doing with measles also. So our response simulation, again, revealed both strengths and weaknesses. We have a lot of strengths. All right, our number one strength here is that this county has more coordination and communication within its walls than any other place that I'm associated with. There are 13 counties that we meet with on a monthly basis, and my counterparts don't nearly have the communication with other departments that I have. We have an excellent working relationship with our public communications team. We have an excellent working relationship with our emergency management staff, and that makes these problems seem, I don't want to say trivial, but it's much easier to integrate public health into those because of those relationships. Those were built years and years ago. I'm just trying to help cultivate those even further. I've got good relationships with them. Jackie started this program 10 plus years ago. She started those relationships, and we've just built upon that ever since. But my counterparts in other counties that surround us, they don't even know who their emergency management coordinators are. They don't have conversations with them. They don't have dealings with them. They're public information officers. They put out all their own stuff. So we really have a good structure there. Public trust is our biggest thing, right? A lot of public trust was eroded during COVID, and it's going to be hard to get that back. And we have to do something in order to get out into the public and gain that public trust back from our community. I think a lot of our vaccine hesitancy, especially with new kindergartners, stems from that COVID pandemic that we had. So working to get those public health, the trust back up again is key. And public health has done a lot recently to do that. Since Tracy got here, we have focused a lot more on going out into the community as opposed to having the community come here. We're doing way more outreach events now, I think, than we have since I've been here for 5 years. And I think that's really important to get out there in the community to start building that public trust. All right, that's all I have. Does anybody have any questions or comments, statements? Yes, sir.
I think this was very nice. That's some very good information. I just wanted to ask, you mentioned something about misinformation, and I wanted to kind of get an idea. Has there been misinformation? I'm going back to COVID. I know we had a lot of misinformation or disinformation during the COVID timeframes. So I was just, when you mentioned something in your presentation about misinformation.
So a lot of there's a lot of misinformation out there about vaccines in general, okay? And it typically ties back to, and I'll let the CD team talk more if they want to, but a lot of it ties back to the autism rates and how the autism rates are growing. There's a lot of conversation between vaccines and the growing rates of autism. So I think that's where a lot of the hesitancy comes from. And then, quite frankly, we're vaccinating, there are more vaccines that are given now than when you and I were growing up, right? And a lot of that, a lot of people are taking pause and saying, okay, maybe I don't give my child 36 shots within a year or whatever. I don't know what the vaccine schedule is, but spreading those out a little bit. But the biggest one that I've heard of is the link between, or the alleged link between autism and vaccines. You mentioned that.
I would say another thing is like makeup of vaccines, manufacturing processes, chemicals. A lot of people are very aware of the chemicals of really everything that they ingest. So I think that is another reason that kind of people take pause of it. But also, there's other things to keep in mind that, are also problems, like food. Yes.
And a lot of the misinformation also comes from social media. You know, it's
Most of it.
yes, yes. I mean, it's funny. So my wife and I sit on opposite ends of the political spectrum, and she and I can be scrolling through the exact same social media channels, and she's seeing one thing and I'm seeing something completely different. And until the public understands that all of these things, your Google searches, your social media searches, are geared toward what you've looked up in the past, right? And they're not looking up scholarly things. They're looking up Dr. Google, all right, or Dr. Phil, not a real doctor, but they're taking information from non-credible sources.
And it's very biased.
And it's incredibly biased. So that's where that misinformation comes from. Dr. Keener did such an amazing job during COVID, getting out there in the community and having these one-on-one conversations with political and spiritual leaders who the community trusts. You know, they oftentimes don't trust the government, but they will trust their spiritual leaders or their community activists. And he went out there, he had those connections with those people. And we wound up seeing a greater number of typically underserved communities coming in for their vaccines, their COVID vaccines. I attribute a lot to Dr. Keener and his outreach. So if we can do a lot of the same things, we can hopefully bridge this gap.
You're going to run into a little bit, you brought up the COVID. So the venues are much different, like the delivery method is much different. Messenger RNA versus the older vaccines, which were much safer. Messenger RNA, a lot of information that was out there is like, what do we know about them? But the lay person doesn't know that. All they hear is vaccine. So they're combining them together when they're very, very different. And I kind of think that to get over that vaccine, because autism was, 15, 20 years ago was brought up and then debunked. And then now it's being brought up again. But I think part of that is just because people are starting to look into it because of the messenger RNA vaccine, not understanding that the older vaccines have a totally different delivery method.
But also 20 years ago, the delivery methods for there wasn't social media.
Sure.
Getting the information wasn't as easy as it is today.
Absolutely.
Right? It's not accurate information.
Right.
It's a lot of garbage in, garbage out, but they're taking it as the gospel.
Yeah, but again, they're just saying vaccine. They're not all created equally.
Correct.
I guess I would say.
Correct. And again, that's part of our job, to educate the community that it is a different type of vaccine and it is historically safe. But we have to get out there and educate them.
I agree.
Along those lines, and understanding, trying to meet people where they're at and give them accurate information, would the community engagement include if you were going to follow an alternate pathway right to it? Because I think part of that becomes the follow through and the timeliness of an alternate pathway. My kids do all have autism. They are all vaccinated, but they did not follow the vaccine schedule in getting it because of seizures from the vaccines. So it took a lot of work on my part, and to still finish it all out.
Yes, but maybe not do all of them at once.
Right. Exactly.
And that's part of that public education.
So will you help people with that education?
Yes.
We welcome anybody, even if you wanted to get one vaccine.
So,
if you want to talk about the rest,
yes,
we happily do that at Union County Public Health.
But not all community providers do. I mean, that's what we talked about.
No, but that's why it's important for us to get information out there, and not just to the historically underserved populations that we have in the county, but to the community as a whole. Get that information out there, because Dr. A may say, no, you need 36 vaccines on day one.
They'll let you go.
And then Dr. B says, hang on a second, we don't need to do that. We can spread it out like we can spread that out over time. But getting that information out there from a trusted source is I think something that that we need to do, and that starts with us.
I just want to piggyback off that. What Amy said, I think some outreach will have to be discussed with the hospitals or the two providers, because a year and a half, 2 years ago, letters were sent out, and if you didn't follow the CDC schedule at the time, you were done and you were let go, and families left family practices. I have a friend that went out on her own and started outside DPC clinic and the clientele coming saying that they are not seeing pediatric care. We've been trying to hit it from the state level as well because of that, because we now have more families not seeking pediatric care. And we've tried to bring this to attention that we can't have providers dismissing pediatric patients because they want an alternative schedule for whatever reason. So
That's a tough conversation, I mean, from my office. That's something that's gonna have to, 2 seats down, can start.
I mean, if it's not part of the conversation, nothing budges.
I agreed, but even if we can just get the information out there to the community and say, these are options, and that we will see you, and if you wanna take one vaccine and then discuss the other ones with our nursing staff or our pharmacist or whatever, with one of our physicians, you can do that. You know, personally, I feel that's a parent's right, but you know, you are true. If they're getting dropped because they're not following that vaccine guideline, then that is something that needs to be addressed, but unfortunately, that doesn't come from my office, so.
That only increases the vaccine hesitancy.
It does, and our numbers are going in the wrong direction. And the longer they go in the wrong direction, the harder it's gonna be to right the ship. And you know, we had, there are several communities and several organizations that were part of our measles exercise that are traditionally vaccine hesitant, and they were there. And it was made very clear that we're not trying to change your mind. We just want you to know what happens. One measles case is not like one COVID case. One measles case is not like one varicella case. One measles case is a huge deal, right? And you know this, right? It's a massive deal. So just having one case because we have an entire, you know, school or daycare center that's you know, vaccine hesitant, hasn't done it, creates a massive problem down the line. So getting them to understand that and getting that education out there to them is one of the things that we're really trying to focus on.
Along the same lines though, it's our insurance companies and Medicaid who also are stringent on that, right? And it's more expensive to not follow that, if you didn't know that. Like you have to pay for some of it yourself. You know, they don't just willingly separate out things, yeah. You know, and whether that's co-pays or, you know, they won't pay for it at a certain time. I mean, like it did cost more money to do that, you know, and so maybe if we could just get information out there on our vaccine clinic, on just different ways to accomplish that.
Absolutely. Listen, we have a wonderful vaccine staff here, immunization staff here. They have a lovely new quarters upstairs that they're operating out of. You know, I'm sure that we can get that information out there to them. But compiling that data and compiling that information and getting things out there with people who are knowledgeable and will answer their questions, both pro and con. Right? What's the pros for holding? What are the cons for holding? I think that's important.
I have one last question.
Absolutely.
And that is, with the increase in exemption rates at the school, is there any conversation on what warrants an exemption? Because currently you just have to say that it is, right? Like.
So right now there's legislation even to propose philosophical exemptions versus religious exemptions only. So, what's that?
Other states have the philosophical.
Yeah. And so I was talking to Dr. Keener once, and he had a conversation with the lawyer that wrote the law for exemptions, and his concern was if we change it, it will be for more wide acceptance of exemptions, whether that be philosophical or otherwise.
And the unfortunate part is with the exemptions is it oftentimes doesn't affect that family. It affects the herd immunity, which affects that 5% who can't get it for one reason or another. And you know, those are the people who suffer from it. Yeah, I mean.
Which is also my family.
Yeah.
We have common variable immune deficiency.
So, I mean, you're the 5% that can't get certain things, and that's the one that's being affected the most. And you go back to the misinformation, people you talk to, they're like, it's just measles, right? right? It'll go away, but they don't look at the long-term effects of what occurs, the kidney issues, the reproductive issues, other things that can come down the line when, 40 years from now because you contracted it because you didn't want to get, your parents didn't get you a vaccine. So we have a huge uphill battle. There's certain things that we can fix very easily, okay? We can fix the continuity of operations plan. We can fix that for the county. We can fix the technical issues. The vaccine hesitancy is going to be tougher to do, but we have to start to at least level off those numbers and get them back in the right direction. Anything else? All right, thank you. Love you, but I'm not staying for your presentation. That's right.
Well, thank you all for inviting us to come and talk about transportation. Transportation Department is one of the 6 departments in Human Services. As I introduced myself before, I'm Laura Gardner. I am the Fiscal and Compliance Supervisor, and that includes safety. And Brandon is also going to speak during this presentation. He is the manager over operations, which includes our dispatch team and our mini drivers, which I'll go over those numbers later on. We report to Teresa Torres. She's the Director of Transportation. So the mission of transportation is to provide our residents with reliable and efficient services in a safe and cost-effective manner. We live by this mission, reliable and efficient services. We maintain our vehicles to the highest standards. We are very strong on meeting on-time performance, and we have very clear communication with our passengers. We are very safe. Transportation has their own safety officer, and they are responsible for our training program. They're identifying hazards, and they're looking at ways to reduce risk. And then in a cost-effective manner, you're going to find out later on in the presentation a little bit about our funding sources. Transportation is very fortunate to have a lot of different opportunities to get reimbursed for their services. Go ahead.
All right, so let's talk about who can ride on Union County Transportation. So any resident of the county is eligible to ride. Those that are ages 0 to 15 can ride as long as there is a parent or guardian that is accompanying them. If you are 16 and over, you can ride as an adult. Passengers must be registered with Union County Transportation. I know that Laura's going to go over later the registration form and some different ways that we can access that. And currently there is no cost to our passengers. We have, like Laura mentioned, we have state and federal funding that covers most of the cost, and she'll talk about that later as well. Transportation has been very intentional in trying to get out in the community and advertise our services and who we are and who we serve. We want to figure out what that unmet need is and try our best to meet it. We have created cards like you'll see in the bottom left there that gives our main transportation phone number. It gives a QR code that will send them to a link to register. And then in the right corner there you see for the rider's guide. And this rider's guide is for anyone once they are registered. It includes information regarding our guidelines, our policies, and just general information. There's also a QR code for that as well.
So registering with us is very easy. If you go to the Union County website, there is a form under the Transportation Department. It has 5 sections to it, and it only takes a few minutes to fill out. It's basically looking at information to confirm your residence, understand your mobility issues if you have any, emergency contact information. It does ask you to review our policies and then basically submit the form. Once that form's submitted, our office staff is looking at that, reviewing the information, they're contacting you, and within like 24, 48 hours, you can call up and ask for a trip. It's very quick service, and Teresa's actually working with Jackie to set up some kiosks in the Human Services building so that when residents are coming in to go over DSS services or public health services, they can go to that kiosk and they can actually go through the form and sign up for our transportation services. But it is very easy to do.
All right, so where do we take passengers? We take passengers to medical appointments. We take them to work. We take students to school at SPCC. We transport older individuals to adult daycares. We transport people to recreational opportunities. We take people shopping. We take people to nutrition sites to get nutrition. We also go into Charlotte. We go to the VA in Charlotte. We take passengers into Charlotte for medical appointments. And then we also go to the VA in Salisbury. So just some general information. Staff-wise, we are a staff of 48. Most of the staff is drivers. The breakdown of that is we have 16 full-time drivers. We have 5 benefited part-time drivers, and then we have 13 part-time drivers. And then our 12-member office staff is made up of admin, safety, dispatch, supervisor, and management staff. And then we also have 2 fleet workers. These are individuals that come in on the weekends, on Saturday, and they wash our vehicles for us. As far as our fleet goes, we are a fleet of 28. 23 of those vehicles are ADA accessible, meaning that if someone has a walker or a wheelchair or needs a ramp, they can access the vehicle and get a ride on 23 of those 28 vehicles. We have minivans, we have transit vehicles, and then we have what we categorize as LTV, which is similar to what you see in that picture above there. We have 20-foot and 22-foot vehicles, LTVs. And then we also have a dedicated mechanic, which resides at Patton Avenue. This position is listed in the Facilities and Fleet Organizational chart. And then we are also committed to being environmentally friendly. We have began the process of converting all of our vehicles to biofuel, meaning that they run on propane as well as gas. Those vehicles will run, they'll start out on propane, and if we run out of propane, then it will transition over to gas. Currently, we have about 1/3 of our fleet now that has been converted, and then every new vehicle that we get, every vehicle that we replace out will also be converted to propane. And we have a fueling station now at our headquarters over at Airport Road. We have a fueling pump out there where our drivers can fuel before they leave or after they're out, they can fuel on site. And then we also have a site where they can fuel out in Marshall. So when you're looking at operations, one of my main priorities outside of making sure that we're safely operating on a day-to-day basis is making sure that we are as efficient as we can possibly be. We all know that the more efficient that we can be, it just means the more people that we can serve, the more opportunities that we have to help. We try to maximize our resources, our time, our vehicles. So what this chart does is it's a breakdown of the last 3 fiscal years, and you can see, without going into a lot of detail, we'll kind of break it down for you here. Our trips have consistently been going up. They have gone up from about 303 trips a day in 23 to in 25, they're about 329 trips a day. So that steady increase of trips is definitely something that we take pride in. And then our wheelchair trips have also substantially gone up. Those went up from 14,000 plus in 23 to now 16,000 plus in 25. So right now we are doing about 350 trips a day. Our drivers are out operating about 180, 190 hours a day, and they are driving almost 3,000 miles a day. We are a very dynamic, transportation is very dynamic, and for anybody that knows anybody or has anybody that is interested in transportation, please let them know that we are here to serve them.
Yeah, I just wanted to point out something on this slide. you see that we provided 81, I'm going to do that fiscal year 24 amount, 78,000 trips that we provided trips in the county and around that year in 12 months. That year we only cost the county $484,000. Our payroll for our 48 staff is about 2.2 million. That's just our payroll, that's not our other costs in our budget. And so to see that we only cost the county then at the end of the day 484 for that, that is because we have so many funding opportunities that we can use. This chart, there's not a lot going on in this chart except to say is all of our grants and funding opportunities that we have to us. Teresa, who has been with the department for 9 years, has grown in her knowledge on all the grants that she can write and get funding for. And I know Jason was mentioning other counties and talking to them and finding out that they don't have other good relationships with other departments. Well, we've met with other transit agencies and we found that they don't have a really good knowledge base of all the funding opportunities they have. Because we have all this funding, we're not charging our passengers anything for those trips. And we're really saving the county in a lot of ways in providing those operations. On this chart, one of the biggest grants that we have, it's our 5307 grant. And with our capital portion of that, for 5 years, we're going to get about $4 million. And so that capital planning requires a lot of coordination with our facilities department procurement to figure out how we're going to spend those funds. But most of that funding is going, and then, you know, we have a lot of initiatives, of course, as all the departments in human services do. One of the biggest initiatives we've had that's actually covered a number of years is our routing schedule platform. We've been working on that for a number of years. We just went live with that July 1st. This is a very incumbency platform. And but this is going to help us once it's up and running in all the different ways. It's going to really increase our efficiency. We're also working on, with all that funding we're getting for the capital grant, there's a lot of strategic meetings on how we're going to use that funding and be cost effective with that. We're also looking at satellite locations for our vehicles for overnight storage in the county. And then one of the big things that we're doing is continuous involvement in regional, state, and federal transit and the initiatives going on. If you go to the next slide. So Teresa and Janet actually went to DC to discuss legislative matters with some elected officials last fall. And that's just really important that we have people here in Union County that are going out and having those discussions with those people that are making the rules. And part of that organization that went to DC, that's part of our NCPTA. That is an organization that is an advocate for transit agencies in North Carolina. There's 95 transit agencies that they represent. They do advocacy, educating, training. They also do awesome conference events once a year, of which Teresa is a co-chair for that event. And if you look at that top picture, the event in May had a big rodeo, which they allow bus operators to compete against each other. And so there was about 90 plus drivers from around the state that competed. We actually were able to send 6 of our drivers. They performed very well. And there's a picture from a previous year where our drivers did place in the competition. The middle photo actually is just to highlight Brandon, because Brandon was one of the judges. He's actually laying on the ground watching this large fixed route bus go through some tennis balls, just making sure everybody was on the up and up. And then another picture shows one of our vehicles, the kind of obstacle course they went through. And then I know Brandon mentioned we work very heavily with our public communications department. One of the lower pictures is one of our passengers, Ms. Kinlaw. She's very involved with transit advocacy, and she's one of our go-tos when we're doing like any kind of public communication awareness videos. And so that's a clip from a video she was in talking about our services. And then the last picture on the bottom is our propane tank, which is actually just a really big deal for us. And it's one of the grants Teresa wrote that we were able to get that propane tank. We're saving on fuel costs, and we got 80% coverage on those costs because of the grant that she wrote. that's basically it on transportation. Do you guys have any questions?
I wanted to ask a question. Since Medicare, or Medicaid rather, came into play with the transportation, some of those increases, are many of those increases in the rides from Medicaid clients?
So we did have an increase. I can't specifically exactly what the increase was, but I know that we have increased our residents that have Medicaid coverage on both the direct Medicaid and the brokered Medicaid side. And it's definitely, we work heavily with the DSS department on those clients. And that funding opportunity actually is uncapped. And so definitely if they have Medicaid coverage too, that we try to use that as our first funding source.
I have a question. The grants, can you describe what some of the grants are? Are they federal and state? Are they a combination? Or?
So some of the grants. So there was one grant up there that was called the ROPE grant, and that's through the state. And that covers employment trips, trips of clients going from a rural part of the county, traveling in that area. Then we also do, oh, I'm so sorry. I'm sorry if you can't hear me. Oh, thanks, Brandon. Then we have other grants that are specifically, that have been written to cover our trips that we provide. Like the first 6 grants listed are basically to cover our trips. So we develop a trip cost based on what we've done historically. And then in the grant, we use it to cover those trips. And so we also have grants that cover our capital. That's a state and federal grant. And then we have a couple other grants that cover our payroll, our administrative payroll, or some of the management payroll in the department.
But are they like public funding? Is it public funding? What is the source of the grant? Who's giving them this money out?
So it's through the FTA. Are you talking about the Federal Transit Administration? Yes, so a lot of those grants are with the Federal Transit Administration that the grant is written. In some cases, we are a direct recipient on that funding. In other cases, the funding is going through the state level, and then we are a subrecipient of that funding. There's other funding that goes to our regional planning organization, and we're getting at the funding. In almost all those grants that are listed, there's different ways of accessing that funding and getting reimbursed for that funding. So it does require a lot of legwork to get at that funding and then get reimbursed. In which, like I was kind of mentioning before, we actually, with another transit agency, we met with them and we found that there was a lot of funding opportunities they were not utilizing, which meant that they were providing trips and then their county was covering the cost of those trips because they didn't have they weren't accessing some of the funding sources.
In addition to the federal funding, just because funding is a benefit, so I want to make sure that we give a shout out also. The state provides one of the funding sources, which is ROPE, and that was listed there, and that is from the state legislature versus federal dollars specifically, and that's something that actually had been removed a couple of years ago, and they reinstated it, so that's a very good thing. We could utilize more at the state level, but obviously there's a lot of competition for that funding. And then the other funding source that we utilize is Home and Community Care Block Grant, which is actually part of the Older Americans Act, so it's specifically for people ages 60 and older. And I think those are the only non-federal, right? Yeah.
I just have a question. Do you guys have a no-show rate, like when you go to pick up people and they're not there?
Yes, we started a no-show fee last August. It's $10. Depending on the situation, it might be waived, or the current clients, like we don't charge Medicaid clients. There's other type of clients we might waive or look at the situation and not charge that fee. Right now, being in our new platform, as we work out some of the pieces of the platform, we're not charging a fee right now either, but we expect to reinstate that
you know what the rate is of like the no-shows of people that, is it daily, is it multiple
It's
times a
daily.
day?
I don't have the rate offhand. I can share that next time. But us and all the other transit agencies have a high no-show rate.
Yeah, and it's annoying because it takes rides away from other people, right? So if we're gonna provide a service, we want people to be able to use it.
And we have multiple ways that we try to avoid no-shows, right? So we have an IVR system that will call the passenger the day before and remind them that they have a trip and remind them where they're going, what time the trip is, when to be ready. And then our drivers also have the ability on their tablet to call out to the passenger when they are en route to their house or when they are at the stop before them. So we do everything that we can in our power to make sure that the passenger knows that we're coming, that they have the ride with us, that we're on the way. Because like I said, we don't do no-shows for a money grab or, like you said, it's more about the seat and the opportunity that that person took that someone else could have had.
If you have a repeat offender, are they still allowed to utilize the service, or are they told they can't utilize the service anymore?
So once you get 3 no-shows, you can be suspended for up to 30 days. And then it goes in severity from there. Once you're off suspension, if that continues, then it increases up to losing your privileges.
I think that's good, yeah.
When you say trip, is that door to door or is that a route that y'all run?
It's door to door. We're curb to curb, door to door. But yeah.
And are there limitations on the time? I know in the past, and maybe it wouldn't fall under y'all, but there had been discussion on ways to get some transportation options, within the county. And I understood then that there might be a problem if you had a late appointment in Charlotte, right? Like a 4:30 doctor's appointment, can you get someone home from it?
No. So.
Our operating hours are from 6A to 6P. So we try to get every one of our drivers back to base or finish with their route by 6 p.m. So we have to be strategic in how we stagger driver start times, right? Because we don't want to flood the market at 5 a.m., 6 a.m., pick people up, and then have nobody, in the late afternoon or early evening to be able to pick people up to take them home. So we're strategic in how we stagger the driver start times. We have to be mindful of driver hours. We only have a certain allotment of vehicles and a certain allotment of drivers and hours in a day. So we take people into dialysis as early as 5:30 in the morning now. We pick up, the latest person that we pick up is 5:10, and that is from Tyson. But those real early morning and those early evening trips are trips that we take on as a kind of case-by-case basis. Just depends on where they live, how far they're going, what they need.
And I will say, like, the dialysis and the medical offices know what our times are, so they're very good at giving our passengers the times within our time frame. We are missing. There is an unmet need. That's just a hard nut to crack to figure out what that is, to be able to say we need to extend our services. So. Thank you.
Good evening. Thank you so much for your time and the opportunity to share this information with you tonight. For those that have been here before and done this, we do this each year. It's a more comprehensive update of the rates of communicable diseases for our county, and it is based off the calendar year. And the information that I'll be presenting to you tonight is from the calendar year 2024. Here's just an update or overview of the reporting categories that we'll be reviewing tonight. And The annual review of communicable diseases, again, just provides a comprehensive overview of the reportable infectious diseases within our jurisdiction. And it just kind of highlights some trends, emerging threats. We go over some key public health responses, and then just some insights on the burden of disease, the effectiveness of surveillance and control measures that we implement. I'd also like to point out that we get all of the information from the North Carolina Disease Data Dashboard. That's updated annually, and you will see that a lot of the information we have, we are reporting case rates in this presentation, which are the number of cases of diseases occurring in a population during a specific time, and indicates how commonly diseases are reported for our jurisdiction. And then there will also be reference to the incidence rate, and that's the number of cases of disease in a specified population. It's usually expressed in per 100,000. And it indicates the risk of disease in a specific population. So your case rate is going to fluctuate a lot with census, whereas your incidence rate kind of highlights the actual risk in a population. And while both values carry great significance, we're only going to, just for consistency, because it's what we've reported in the past, we will report mostly case rates and can only compare the incidence rates for previous years. I tried to put both on there and it just looks a mess, so that's for everybody's benefit. But the data dashboard is public facing, so if you have any interest in incidence rates from past years, please feel free to reference that. So for our enteric food and waterborne illnesses, you will see that there were notable fluctuations in several of the enteric diseases compared with historical averages. And for the historical averages, we go back for 5 years. Rates of Campylobacter, Cryptosporidiosis, E. coli, Salmonella, and Vibrio infections were all above average. This could be due to reflections in environmental, behavioral, and reporting factors. Campylobacter and Salmonella remain the most commonly reported bacterial enterics, and their increases just underscores the need for continued efforts in public safety education, food safety education. Our environmental health staff does a great job, and we collaborate a lot with them to provide some of that. Also, with each case that we get, we review that information with those patients, so hopefully they're not recurring infections. Also, outbreak prevention. There was a Salmonella outbreak in a child care center, and that contributed 2 cases, but also with those 2 cases would not, obviously there's 20 other cases that we're looking at as compared to the 5-year average. So it's been really important to get that information out to those positive cases. The rise in cryptosporidiosis also may suggest seasonal exposure risk, recreational water contamination. I will say that we did not have any epidemiology linked cases, which means just not a common link or common resource source. Vibrio, also that's usually associated with raw or undercooked seafood. We always screen for that. We did have in 2024 a recall for oysters. So we get that information out to all of our distributors, and environmental health is really great about going and ensuring that those lots are disposed of. In contrast, cases of Legionella, Shigella, and Cyclosporiasis were lower than average. It could be attributed to more stringent building maintenance for Legionella, and then changes in travel patterns. For vaccine preventable, I don't think it's a surprise to anyone. We did experience an increase in case rates compared to previous years. This trend is concerning, and signals a potential shift in immunization coverage and population immunity. Transmission dynamics within community, travel are all considered potential contributors. As noted on the slides, increased incidents was a big in pertussis. We did have a significant outbreak, not just in Union County, but across the state as well. Big increases in pertussis, but we kind of expected that. And that particular outbreak started at a public school, began in 2024, and then it just ended earlier this year in 2025. Overall rise in vaccine preventables really emphasizes the continued importance, like Jason mentioned before, education, ensuring timely access to immunization services, and we are really good about looking at our schedules and ensuring that access. We've also, even this year, increased our number of outreaches where we're administering vaccines in the community, and we'll continue to work hard for that outreach in the future. Also strengthening partnerships with healthcare providers, schools, community organizations are all really vital to addressing that vaccine hesitancy and improving immunization rates. This is a little bit harder to read, but just kind of give some information. Also, this is available public facing with the respiratory surveillance dashboard, but kind of give some information about the patterns in the flu season. This season showed distinct temporal and severity features. We saw a marked spike in deaths, and influenza-like illness really started kicking up in early February. And I will say, just because the flu season runs a little bit differently, this information is the 24-25, so a lot of that information will be current for this year. But high severity as well. This gives a little more information more broadly about respiratory virus surveillance. Overall, respiratory burden with really substantial activity from multiple viruses at different points in the season. And this makes a huge difference, especially with demand on healthcare. You'll see that in December, there were several weeks where RSV also even had outweighed positivity than influenza. And again, these are vaccine preventable diseases. So decrease.
Is that MPV or RSV, the purple?
That is, oh goodness. It is human pneumo, yes. Yeah. Yes. I was going to say it's right there. But yes, it's the metapneumovirus. All right, and for our direct contact respiratory, for TB, I'll go into a lot more detail in the next slide, but as you can see, we had a pretty active TB year with active cases. And for group A strep, we did have an outbreak at a long-term care facility. There were four infections included with that outbreak. We were able to work really quickly with the long-term care facility and get that outbreak contained, but that did contribute some to the increase. Invasive group A strep, you'll see a lot with, we have seen with wounds, also IV drug use. We did see an increase in number of infections last year from IV drug users. And so with the active TB cases, one of the biggest reasons that is such a heavy lift, with each active TB case we get, on average, it takes about 40 hours to complete that investigation and get that patient started on medications. And that's just for the initial response. These active cases We do direct observe therapy for we try to do every dose that besides the weekends, but initially we go out to the house every day for the first initial phase of that treatment, and then afterwards we do televisits with patients to observe that therapy. Through those 6 cases, we had 333 contact investigations. With those contact investigations, we do offer testing for each of those patients. Now, not everyone, because that testing is optional. Not everybody opted to do that testing. I would say about around 160 actually decided to opt for testing for that. And then some of them are lost to follow-up as well. For TSTs and IGRAs, TSTs is tuberculin skin test, and the IGRAs are serology, so blood testing for latent TB. For high risk, we did 704 tests. So for the contacts listed, sometimes we have to do 2 tests. One when we are initially notified, and then 8 to 10 weeks after notification, just to ensure that that is a true negative and they haven't converted in that period. Low risk is considered like those that need it for school or for employment, and we offer that service as well. Out of those cases, or even those that are reported, so we do, LTBI is also reportable, and we evaluate those cases. So anybody who has or is identified to have tuberculosis, we rule out active TB. So we do chest x-rays and screening for symptoms, and if they are not active, it's latent, meaning they are not infectious to others, and they are not symptomatic themselves. We offer treatment for everybody who is identified with LTBI, and that is also optional. They are not required to do treatment. Out of those cases, 63 were initiated, 21 were completed. Now, some of those cases, 30 actually, carried over to 2020 this year, so 2025, and then we will report those out this year. 12 incomplete treatment. Sometimes people do not complete treatment because of symptoms. Some people it just does not suit their lifestyle and they decide not to continue with that. We do everything that we can to ensure treatment. Sometimes we do have to change therapy if it's due to symptoms. And then the others either declined treatment or lost to follow-up. Treatment not indicated. Typically, that's with people who are identified with LTBI and they say, oh, I was treated for active TB back in 1989. We do our best to get those records and ensure they were treated appropriately, but for that population, we would not recommend retreatment at that point. This year, illness spread by insects and animals like malaria and Lyme disease did not show any significant fluctuation. The noted increase was in dengue. These were both travel-related cases. I think, just that alone just kind of highlights the importance of education. Again, if you're traveling, it's going to be really important to get that prophylaxis because when they are infected, when they come home, that presents, potential for spread. All right. We did not have any events of Creutzfeldt-Jakob disease. Meningitis, we did have an increase in cases. No outbreaks. We didn't have any noted secondary cases. So with the meningitis cases, each event we get, we collect contacts. We do offer post-exposure prophylaxis, so antibiotics to prevent infections to those close contacts. And so we did not have any secondary cases related to any of those. CRE, these are basically drug-resistant organisms. These organisms have a mechanism to actually break down the antibiotics. So we have a close on those. It's really important to do surveillance, especially for long-term care facilities. We did have a lot of those were contributed to either hospital stays or long-term care facilities, and we work really closely with long-term care facilities to make sure the control measures are implemented, infection control. Sometimes we go in and do assessments for the long-term care facilities as well. With the meningitis, I did want to mention, in 2024, we had a notification for our region. There was an increase in Cipro-resistant and penicillin-resistant strains of meningitis. This was caused by Neisseria meningitidis serogroup Y, which is a very common strain of meningitis. And then this resulted in discontinuation of utilizing Cipro as a prophylaxis to close contacts. And this, in our region, it was Cabarrus, Gaston, Iredell, Lincoln, Mecklenburg, Rowan, Chester, Lancaster, and York County. So South Carolina was impacted as well. This was a change in our routine recommendations, and through that we sent out notification to local providers, and then we monitor every single person who every contact, just to make sure that they are treated appropriately, because people do seek post-exposure prophylaxis from their primary care providers. So, when those things are not, when we know that, they're not using best practice for, and some providers don't know, they don't get the memo, so we just reach out to reiterate that information. In 2024, we did have 7 outbreaks of other communicable diseases. This included respiratory illnesses, gastrointestinal illnesses, vaccine-preventable diseases. Those were the most common causes of outbreaks. Again, the pertussis was one of them. And this included different places as well, long-term care facilities, schools, child care facilities as well. It just kind of highlights the importance of doing ongoing surveillance, rapid case investigation, community engagement. We have a really great group of CD nurses. We also have a really great relationship with our community partners, our CCHC nurses, so we can get that education out there quickly. And you will note, COVID outbreaks are still reportable, not individual cases, but we do have, and that's primarily long-term care facilities. All right, sexually transmitted infections and bloodborne diseases. Good news, chlamydia and gonorrhea rates went down a little bit. Also, congenital syphilis and primary syphilis rates did decrease. A lot of that we can attribute to a lot of the education. For those that remember the 2023 update, those cases were skyrocketing. And so those trends are also reflected really throughout the nation in North Carolina. So just kind of highlights the importance of education, getting that information out there. Some of the rates that we did have an increase in HIV with newly diagnosed patients, and then hepatitis B. Some of the hepatitis B, a lot that we've seen personally, and kind of made notes, a lot of it, especially the chronic, are from other countries. So those that don't have access to routine vaccinations like we do in the U.S. And the big news, our immunization review. Total vaccines administered did increase. I think last year it was a little over 6,500. So our benchmark report is run every October, and these benchmark reports are for ages 24 months and below. And this is for both internal clients and countywide. And when I say internal clients, I mean for our child health patients, that we are their medical home. We have patients, for our child health clinic, we see Medicaid, uninsured. We are the safety net for uninsured children in Union County. And so primarily, that's what we do our outreach for. At this age, children have received a bulk of their routine childhood vaccinations, including protection against most all vaccine-preventable diseases, including MMR and varicella. And then I would say this is a notable decrease. Some of these patients, especially the internal patients, they did have declinations on hand for those patients. And then county residents, we do provide outreaches, we provide education, and then we do have some providers that reach out to our immunization coordinator just to get some information. And we send out, for really countywide, we also send out postcards to remind patients. We try to do that at least once a year, hopefully twice a year if we get to it. But just to remind those parents, your children are not up to date with vaccinations. While the causes of declining vaccine coverage, we've discussed it. It's complex and multifactorial, but contributing factors may include reduced access to healthcare services, vaccine misinformation, and then, as mentioned, just the shift in that public perception regarding disease risk. Risk versus benefit for vaccinations is a hot topic right now. So until some of that perception shifts, I think we're going to continue to see those declining coverage rates. We do offer vaccines for underinsured, uninsured at no cost. So that is to increase access to vaccinations and lower those barriers. Lower vaccine coverage, it poses significant risk and is a great public health concern. That reduced community immunity, increase the risk of outbreaks, which really impacts those that they're not able to get vaccines. Your 3-month-old children, they are not eligible for MMR, and even under abnormal circumstances. So even if we were in a point of outbreak, they still would not be eligible for those vaccinations. We've already talked about some of the implemented strategies to address these issues: expanded outreach and enhanced reminder or recall systems. We work on that. And then collaboration with those healthcare providers and targeted community education. This is just a little bit about some of the outreaches and specific efforts that we've done. Last year, we continued to offer STD testing for uninsured males. Currently, the state does offer free testing for females for gonorrhea, chlamydia, syphilis, and HIV. Also, MSM, they are eligible for free testing. Uninsured males, they offer HIV, syphilis, and gonorrhea. So there is an out-of-pocket cost for chlamydia. And we were able to use some funding to ensure testing for those uninsured heterosexual males. Continued using preferred testing. So IGRA is the blood testing, which tests for the TB antibodies. We offered that testing for high-risk patients at no cost to them. Unfortunately, that funding has expired, and so we're working on ways to kind of help fund some of that testing. So more to come on that. Outreach events, we did hepatitis A, flu, and COVID vaccinations at the Union County Shelter. We did do a significant Tdap vaccination outreach to boost vaccination rates for child care providers. So overnight, well, it was 96 child care providers across the county. We did it in clusters. So we went out to each child care provider that opted for us to come and visit. We did health education, other health resources. We did blood pressure screens and helped connect those child care providers to low-cost medical homes. So those that did not, because a lot of those population they're very vulnerable. They work with children, but also they do not have health insurance. So that creates some barriers to healthcare access for them. Vaccine lookup for school-age children at multiple community events. We usually try to go out to many of the back-to-school events just to make sure parents are aware that we offer these services. They're aware of vaccine schedules and how they can get the vaccines. This year, we're kind of shifting some of our models to actually go out to these events and provide the vaccinations, which will be something we continue to carry over to the years. And continued utilization of our mobile unit. That unit was purchased during COVID to help provide access to testing and vaccinations. Well, we've kind of, tried to use it in other ways to decrease barriers for service. Vaccinations, we did STD testing, which was really well received. Also continue to collaborate with Union County Public Schools. We attend their school health meetings and provide guidance. Anytime they have communicable disease, we have a really great relationship, great communication with Union County Public School. And I mean, it's just really great because anytime they have any concerns, we have very fluid communication with them. All right, some key threats for the 2024 CD program. We did have there was a significant pertussis outbreak, ongoing H5N1. Whenever we get notification, if we have a notification of an exposure to H5N1, we do monitoring. So we reach out to those patients, screen for symptoms throughout their monitoring period, and then report back to the state for any symptoms that have been reported, or arrange testing if they report any symptoms. Knock on wood, everybody's been asymptomatic. Bacillin shortage and the management of syphilis treatment. So for syphilis patients, but for pregnant women, they cannot receive doxycycline. You can't get that during pregnancy, so we have to manage that stock and inventory and prioritize pregnant women with bacillin. Salmonella outbreak, there was, Craig, do you remember what county that was in, the salmonella outbreak? We did have a few positive cases of salmonella. I think it was from Cabarrus County that they had a celebration, and it was a foodborne outbreak that we had some response to. And then, like I mentioned before, we had those resistant cases and an increase in meningococcal disease. Also, the measles outbreak, which I'll go over a little bit. I figured everybody would appreciate a little overview of the response so far. And then there was another wave of Mpox spread. We did have one case last year from Mpox, whereas in 23 we had no cases. So there was another little wave that we had to respond to and educate with. All right, and so for the measles outbreak, I won't bore you with the details. It's all there in your packet. But I'm sure everybody was aware that there was a case in North Carolina. We did have one resident that was a contact of that case. With those cases, we do assess, so if we get a close contact for measles patient, we do assess for immunity. So the first step is to look at vaccine records or any other proof of immunity. If that person is not immune, we do active monitoring. So we reach out to that person every day through their monitoring period And then if they report any symptoms, we do arrange for testing. For those that are immune, it's a passive monitoring, so we give them a list of symptoms. You monitor yourself through that monitoring period. Obviously, give them our information in case they do have any symptoms. But then if it's no news is good news in that case. And then for luckily there were no secondary cases reported from that visitor. They were not from North Carolina, they were here visiting, but they went basically everywhere they could while they were here. They went to a water park and ice cream and another little fun park, so they were busy, but luckily no secondary spread. We've also noted an increase in measles contacts through travel as well. We've had probably a total of 5 exposures so far, knock on wood. And we're really good and diligent. And for most other communicable diseases, we're able, if they're lost to follow up, we send them a letter and close it. For measles, we actually have to hand deliver those letters out to the house before we close them out as lost to follow up. And then I won't harp on this a lot, but as we mentioned before, vaccine coverage rates, and we get this information from the North Carolina Kindergarten Immunization Data Dashboard. That is also public facing, so you are welcome to look up this information. But they just updated that last year. So in 2021, vaccine coverage rates for kindergarten age children was 95.5%, which is above what's considered herd immunity. This year we're at 88.6, which is really, really concerning. Conversations that I've had with school nurses so far indicate that it will most likely be lower for 2025. So, you know, in our efforts to kind of combat some of that, we're really working hard at getting information, education, anywhere that will have us. And that is it. Thank you so much. Any questions? Yes.
First, I want to say thank you for this wealth of information. I applaud those outreach efforts. But when it comes to the board, I kind of liken it to like insider trading for, like, say, Congress per se. So we hear all this great information, and I don't know the answer for the question I'm getting ready to ask you or Janet. But is there any way that, I mean, for the regular lay person, I mean, I know this is recorded, Megan has stuff to record it, but we get a lot of wealth of information, but the lay person, how can they get some of this information so they might be able to help their families to be knowledgeable about what's going on in Union County?
Right, and that's one of, we have worked in the past at providing and we still are, not that we've halted any of that, but we're working on doing a communicable disease dashboard for our county specifically that would be updated monthly. It would provide just-in-time information, so we're working on getting that, and it would be, you know, it would be on our public health page that providers, parents, schools could go on there to really look at what's circulating most commonly here.
Most of the homes, like you said, the long-term care homes or whatnot, they might have the information, but for the regular lay person, maybe there's some type of conduit where this information could be placed out there more for the public to see. You said, only thing people see stuff on, like when it came to infant deaths before.
Right.
And I asked the question, oh, why is there so many of this ethnic minority, which has such a larger rate of infant deaths? So, and then we said, the answer was, maybe it's education, or lack of education rather.
Right.
So I was wondering, how could we?
Or one thing that we're doing in addition to the information on the Union County NC.gov website, which on the public health page, we have a lot of this information along with the dashboard, but there's educational material there as well. And the county has a newsletter that's for the public. It's called the Union County Horizon. And it is a weekly newsletter that goes out, and it has different educational components about immunizations, about water safety, about lots of, basically all of the county departments. It's different material each week. And so this type of material is something that is covered in that Horizon newsletter as well.
So
Obviously at a very high level. But if someone then was interested as a teaser, right, then they could go to the website and get much more detailed information. And then beyond that, if anybody actually had questions, our team would certainly be happy to speak with people one-on-one.
Absolutely.
I think you're doing a lot for outreach.
Say that out loud.
I think y'all are doing a lot for outreach.
Say it into the microphone.
I still didn't hear what you said, Brenda.
She said
I
we're
think
doing
you're
a lot.
You said that Union County Social Services is doing a lot.
Public health.
Public health, especially.
Oh, yes. I was telling them, I was like, I kind of need to share this with our clinical staff because we work together every day, but a lot of them don't know what I do. This is what I do, in a nutshell. Any other questions? I know it's a lot of information and that it's very nuanced, but also multifaceted, so I'll be happy to speak with anybody.
It's getting late, I don't want to keep
It
it
is,
long, but I
yes, let's go
am
ahead.
curious,
Wrap it
did
up.
the state trend in the wrong direction with vaccines as well?
Yes, absolutely. Yeah, this is not something that is isolated to Union County, I can assure you.
And knowing
It's not
what we
just
know
North
about the
Carolina.
kindergartners, do we know if some schools have higher populations for it?
Yes, and that's also in the North Carolina, kindergarten dashboard, you can actually break it down to school, at school level, to see what percentage each school has of coverage. Yes, thank
That's
you.
on
And
the website, right?
it is, yeah. And just to kind of give a little more context of some of the outbreaks. So we took that information, we've built a heat map, and so our goal is to do some targeted outreach for those areas. Thank you so much.
We have no other questions. We'll move on to announcements, followed by public comments.
I know we've all been here a while, so I'm going to keep this really quick. Business operations, one of the things that Jason mentioned earlier was the COOP. Union County as a whole is working at the enterprise level on a continuity of operations plan. And so I'll be working with the directors and the departments and programs to set one up for Union County Human Services. So we'll have a COOP for Janet for Human Services as well as ones for each of the departments. Social Services and Public Health are both required to submit those to the state. So we'll continue to work on that. The county deadline is 10/6, and we've got a soft deadline at the end of the month for our draft. So that's underway. The opioid settlement funding project, Janet has asked me to work with several of my colleagues to work on that for Human Services and for the county. So planning started for that, actually really kicked off in August. We've been talking about it in July. The first component we decided to focus in on was lived experience surveys, and that's for individuals with lived experience in the opioid use disorder space as well as their family members. I did bring some cards, and I can leave those with you if you'd like to take some. We are certainly looking for people to respond. There's a QR code, there's links for the survey, and there's also hard copies in English and Spanish. So that is the first piece, and then we're going to be doing a listening session with people with lived experience through our treatment courts at the end of this week. So there's a lot of things happening in that space. It started in July and August and will run through the end of the year for the planning components of it with monthly meetings. And then I would be remiss if I didn't share with you, Human Services is a work family. And unfortunately, in my shop, specifically in business operations, this month we did lose a staff member. And so I want to take a minute and acknowledge him. His name is Juan Becerra, and he was my human services supervisor that led our language services team. And he passed away unexpectedly on the 23rd. So he was, as I always said, a light in several languages. He was a tremendous team member and led a lot of great projects and initiatives and was always jumping in and helping, and I don't think there was a part of our agency that he didn't touch. So I very much appreciated him and miss him greatly.
So I'm going to provide a couple of updates for community support and outreach. First of all, with senior nutrition, I know that we mentioned at our last meeting that we had municipalities who had joined into the effort to fund the waiting list. And so I'm pleased to provide an update that as of August the 4th, we have 358 people on the waiting list. We continue to vet that proactively. And in July, we were able to contact 51 seniors, and so we started with the municipalities who offered funding, and those are all now completed, and then moved on to clients who would fit into our hot meal routes. And we will be taking 110 people off of the waiting list from the municipalities, as well as the additional funding that the county has provided for food this year, so that is very encouraging. And we're also going to be modifying routes to ensure that the smaller routes have more clients, and so better use of the volunteer time in that space. They also, all the participants have gotten farmers market vouchers, which is a positive benefit to everyone who participates in senior nutrition and just something that's worth shouting out. Also within our WIC program, I definitely want to give a shout out to that team. Our agency has been awarded the premier level of the USDA WIC Breastfeeding Award of Excellence, which is really awesome, yes. We are one of 56 WIC agencies nationwide to receive the premier award this year out of over 1,900 agencies in the United States. So that is pretty cool and a high honor. And that award highlights local agencies that operate high-quality peer counseling programs and demonstrate exemplary support for breastfeeding families. The award is at Gold, Premier, and Elite levels, and Premier's mid-level award, which we like any level award because that's still really awesome. And we actually had previously won the Gold level award in 2021, but this year we qualified for the Premier level because our exclusively breastfeeding rates met the required percentage, so it's based off of a tiered system effectively. And in that space, we also continue to exceed our caseload requirements and got an additional $24,000 in funding due to that work, which is awesome and necessary to be able to maintain the volume. And then just a quick shout out to the Christmas Bureau. We had an innovative campaign this year to raise money for teens, so Christmas in July, and we raised about $2,000, which was just a different type of campaign to begin awareness for the Christmas Bureau earlier versus starting it in November. And we do also have a school supply drive that's currently underway to support our foster children and other clients in need, but primarily foster kids. And then for crisis assessment, I think this is important to mention as well. Our funding for energy assistance is on hold until the state budget is passed. We did get a small allocation of $10,000 in July for that, and that was extinguished in 5 days. So there is not any energy assistance funding to be utilized at this point.
My fellow citizens, this 7:50, and I'm going to be really quick. So, in the social services world, we are mostly staffed, and I believe that deserves a hand clap. There are only a few vacancies in economic services and in social work, and I believe there's only one open in the behavioral health collaborative. So, I'm stoked about that. I am not excited to share with you some of the same news that Jackie shared. We've had a really rough month in human services. Specifically, social services unexpectedly lost one of our senior social work supervisors, and the tragedy of losing a staff member, especially one that was completely unexpected, hits really hard with your teams. It impacted our transportation department also because her sister works there. So just keep our staff, all of human services, in your thoughts and prayers as we learn how to navigate without those two people. Last week was the Social Services Institute, in Hickory, and that is our annual training and come together conference. And I'm excited to share that Union County DSS/Human Services presented several times at that institute and had amazing feedback that we got from all the participants in our presentation. So I was really proud of them for that. The current big priorities in social services going on right now is the Child and Family Services Plan, which means that all of our foster children will be moving to one Medicaid plan through Blue Cross Blue Shield, Healthy Blue. They had previously been split up across the state depending on what LME MCO they belong to, and it was a lot more difficult to navigate, especially if you placed a child outside of the area where their plan was. So this will be the whole state, Blue Cross Blue Shield, Medicaid, Healthy Blue. So we're working to get that implemented December 1. And then the other big thing we have going on is called Path NC, and that is a statewide child welfare information database. Union County will roll into that database in October, so we're currently going through all of our training to prepare for that transition. The last two things are a couple of things I've been asked to participate on. I'll be speaking in September at the North Carolina Department of Health and Human Services Child Welfare Workforce Development event. So I'm excited about that, to talk about how we've done as far as growing social workers in the state of North Carolina, where there are gaps and what our needs are. And the last one is I was invited by Federal Department of Human Services and the state DHHS to participate in Human Services Emergency Response post-disaster, and that'll be in Columbia coming up. Last thing, September 2nd, I'm having knee surgery, so I'll be virtual for a few months because they won't let me drive, which I think is not cool, and I'm going to be stuck in my house going crazy. So just know, when you don't see me at the next couple of board meetings, I'll be on YouTube watching all of you. Thanks.
Total knee surgery?
I'm getting a brand new ACL, and I told them to get it from someone who is much faster so that I will win every one-legged race around. We'll see if that works.
I can't keep a straight face. Sorry. The later it gets, the more giggly we get. I would like to say that our office has successfully applied for and received a grant from the North Carolina Division of Military and Veterans Affairs in the amount of $18,288 whopping dollars, which is fantastic for our budget. The only negative part to that is we have a quick return on spending. It has to be spent by the end of September, but I do not feel like I will have a problem with that. The other thing I want to announce is that Robert Turner and I were recently invited court training put on by the Judicial Center and a group of agencies in Union County. And the plan is to start a veterans treatment court, much similar to the drug treatment court that they already have. So that's our announcements for today. Thank you.
I don't have anything. You had my announcement.
Nothing for me either.
Whatever we decide within the grant.
We will move on with public comments. We do have someone tonight. We have Michael Evela. Is that correct? All right, thank you.
Hi, good evening. Again, my name is Michael Evola. I live at 247 Marin Drive in Indian Trail here in Union County. I wanted to come tonight, to introduce myself to all of you. I am the new Community Engagement Manager for the Community Shelter of Union County. I also serve as a governor-appointed council member and the chair of both the North Carolina Council for the Deaf and Hard of Hearing and the North Carolina Statewide Independent Living Council. Ultimately, I just wanted to come and say, if there are opportunities where we can collaborate and partner, I would love to have those conversations with you. For context, the community shelter, we're the only homelessness emergency shelter service provider in the county, and the councils I serve on, we are state councils where we advocate and advise the state on how we can improve existing or create new services for people with disabilities that impact people with disabilities. So any way we can partner and collaborate, so that way we can more effectively serve the people of our community here in Union County and statewide. I would love to have those conversations with you. Any way that I can be a resource to all of you, I would love to have those conversations as well. So again, I just want to introduce myself, and any way that we can collaborate and partner, I would love to do that.
Telephone number.
Got a business card?
I'm sorry?
Telephone number.
Oh, yeah, Ashley has all of my contact information, but I can.
I want it.
Thank you. Yeah.
All right, if we have no other things, then I'll make a motion for adjournment.
Second.
No one is opposed. Thank you all.
The lived experience survey, I think, great, they have passed down the Share them if you know anybody that might have them, and we're going to have a family survey, and I've got said that all is, but is there any family members that have
Good job. You did great.
Oh my gosh. That's a lovely idea.
You walking out?
Yeah. Except for this. Which was also good, but made me cry. No. Okay, perfect.